Hi, everybody. This is the second part in our alternative kind of airway management lecture about endotracheal tubes and other alternative airways. Okay. So from our first lecture, we learned about kind of pharyngeal airways and the airways that only enter into the pharynx, like your oral airway and your nasopharyngeal airway. Now we'll talk about the tracheal airways. So we have two basic types. You have your endotracheal tubes that are kind of either inserted in the mouth or the nose. They go through the larynx and into the trachea. Tracheostomy tubes are our surgical airways that are created in an opening in the neck, and they go directly into the trachea. So they are inserted below the larynx. And then we have specialized endotracheal tubes or artificial airways. So we have your double lumen endotracheal tubes. We have double lumen airways or combi tubes, some special endotracheal adapters that help with preventing VAP. We have King tubes, and we have something called LMAs, which are laryngeal mask airways. So laryngeal mask airways are designed to use as kind of an alternative to the face mask. So in the first video, I talked about using a mask and a bag and a self-inflating bag to manually ventilate patients. So if you are unsuccessful with that and an oral airway in place, you can insert a LMA fairly easily. So these are a great way to kind of control the air during, like temporarily, like during surgeries they're used a lot, or when you're not successful with tracheal intubation. So if you're in an emergency situation and you can't get the patient intubated and you're not ventilating adequately with just the bag and the oral airway, you can insert an LMA. You want to make sure the patient's anesthetized during insertion or unconscious without an intact gag reflex. Otherwise, you're going to have that laryngeal spasm and MSS occurring. So this is what these look like. There is kind of this dome device down at the end that gets inserted into the airway. Then you have your airway tube that connects to the bag up here. You also have a pilot balloon on these, so after you insert this device into the airway, you can fill it up with air, and that will help keep it seated and secure. So like I said, some indications for this is if you have kind of a difficult to fit mask, so the patient's face isn't, you're not getting a good feel with the face mask. If you've had several unsuccessful intubation attempts, or if you don't have somebody who is trained in intubation available to intubate the patient, and then they do these again electively for some surgeries. So contraindications for this is there is not as much skill needed to put these in, but you still want to still need to be trained to put them in successfully. And because these don't enter into the trachea and seal off the trachea, you do have a risk for aspiration with LMAs. So several advantages are quickly inserted. They can more effectively deliver tidal volumes than just with the face mask and the self-inflating bag. So you'll experience less gastric insufflation, so less risk of patient vomiting because of filling their stomach up with air. If it's placed properly, the patient can ventilate as equally as well as having them intubated, and there's less trauma with inserting one of these than putting in an endotracheal tube. But the disadvantage, though, is again, they don't provide any protection from aspiration. You can't be used if you can't open up the mouth wide enough to insert it. And it can be sometimes difficult to use with high pressure or abnormal anatomy. And again, it's not for long-term mechanical ventilation. Excuse me. Oh, I don't know where. I'll have to. I'll put the links to the videos in the thing, but that's just in a video that's showing the insertion of the LMA. Your combi tubes, these are your double lumen tubes, are sometimes called combi tubes. You have two tubes that run parallel to each other. Once this is inserted into the airway, you're going to inflate the pharyngeal balloon to occlude the pharynx. That prevents the air from leaking out the nose and the mouth. And then there's a balloon at the distal end that will be inflated to seal off either the trachea or the esophagus. Okay. So we use these, again, the indications are going to be similar to LMAs. These aren't used as often anymore now that they have LMAs, or eye gels is what they, kind of the version that they use on the ambulance rigs. That act as LMAs. So they've stopped using combi tubes and King Airways as much. But the indication still would be difficult to fit masks, unsuccessful intubations, or if you don't have somebody that's available to intubate the patient. So typically when I've seen combi tubes, they've come in from the paramedic units bringing in a patient from the field. So contraindications for this is that if a patient has an intact gag reflex, you're not going to want to use a combi tube because that could make the patient vomit. If the patient has any history of esophageal disease, that can be a complication with putting a combi tube in, because when we look at these in the lab, you'll see how big that pharyngeal balloon is. So you don't want to inflate that in an airway that might have esophageal issues. If the patient's ingested any caustic substances, you'd be cautious about using this, just because you'd be worried about vomiting. And if the patient has any suspected airway obstruction, this can potentially cause some complications with that, just due to where it goes. It can lodge things in worse, and they can't be used on patients that are less than 4 feet tall, just due to the sizes of these. So advantages: it requires minimal training. You don't have to visualize any anatomy in the upper airway. You just kind of shove this into the patient's airway, down the patient's throat. You can, easily put one of these in, even if the patient has a suspected neck injury. And because you have those double balloons, you're less risk of aspiration than with like an LMA. So some disadvantages is you have a proximal port that may become occluded with secretions, and ventilation through the wrong tube can occur. So, you need to make sure that you're ventilating through the proper lumen, because if you're not, you're going to be ventilating the stomach. You can cause some soft tissue trauma from inserting these, and again, you'll be able to understand that once you get into lab this week. You'll see how large this is, that balloon is, and how large this double lumen combi tube is. So you can have some damage to the airway when placing it. You can also not suction through this. So because the tube essentially is sitting in the esophagus, most likely. So here's a video that demonstrates how these are placed.
The esophageal tracheal tube is a supraglottic device that providers can insert without interrupting chest compressions and without visualizing the glottis. The esophageal tracheal tube is made up of 2 lumens permanently stuck together. Each tube can provide oxygen to the patient, depending on how it's inserted. The longer blue-colored tube, marked with a number 1, provides ventilations through 8 small openings in the pharyngeal section. The shorter, clear-colored tube, marked with a number 2, provides ventilation straight through the end of the tube. Once inserted, the distal end of the device will either rest in the esophagus or the trachea. If the tube rests in the esophagus, which happens most frequently, the cuff blocks the esophagus and air flows through opening number 1. If the tube comes to rest in the trachea, however, the provider can use opening number 2 to deliver ventilation without having to reinsert the device. The esophageal tracheal tube comes in 2 sizes. A 37 French is used in patients who are 4 to 5.5 feet tall. A larger tube, a 41 French, is used in patients more than 5 feet tall. To insert the esophageal tracheal tube, verify that the cuffs will hold air. The pharyngeal cuff, marked number 1, requires 100 milliliters of air. The distal cuff, marked number 2, requires 15 milliliters. Deflate the cuffs and lubricate with a water-soluble gel. Hold the esophageal tracheal tube in your dominant hand. With your other hand, grasp the tongue and jaw between the index finger and thumb and pull to fully open the mouth. As you insert the tube into the mouth, avoid catching the cuffs on the patient's teeth. Advance the tube smoothly but continuously until either the teeth or the ridge of the gums is between the 2 black rings on the tube. Do not force the tube. Keep the device in a midline position by aligning the black stripe on the tube with the nasal septum. Once the tube is situated, use the large blue syringe to inflate the pharyngeal cuff through the port labeled number 1. Then use the smaller syringe to inflate the distal cuff through port number 2. Begin ventilation through blue lumen number 1, checking for adequate breath sounds over both sides of the chest and over the epigastric area. Watch for chest rise. If the esophageal tracheal tube is correctly seated in the esophagus, you should hear no sounds in the epigastric area when you squeeze the bag mask device. However, if you do not detect chest rise or breath sounds, this may mean that the tube is seated in the trachea. Connect the bag to the clear lumen, marked number 2, and provide ventilation. Verify breath sounds and watch for chest rise. Caution, it's critical to confirm the proper placement of the esophageal tracheal tube because inflating the stomach with air can cause fatal complications.
All right. So similar to the combi tube, we have a single lumen tube called the King Airway. This airway has 2 balloons that are inserted into the patient's airway, and the patient is ventilated through holes between the 2 cuffs. Okay. So there's kind of 3 sizes to these King Airways versus like the combi tubes. It's like one size fits all. And since the tubes are shorter than the combi tubes, it's kind of unlikely that these will actually be placed through the vocal cords. The combi tubes, it's not very likely that it'll end up in between the vocal cords either, but this is even less likely. Like I said, we don't really see combi tubes anymore. They might end up on your board exam. King Airways, I think you may run into these, but even still, these are less likely to be seen. Most of the times the patients either come in intubated or have like an eye gel or an LMA in. So this is kind of the King Airway. And again, I don't know why these videos, when I'm trying to record over them, if I have them actually embedded in the PowerPoint, they don't want to play. But the PowerPoint is posted so you can watch these videos on your own. All right. So, with establishing an artificial airway, we talked again in part 1 about pharyngeal airways that only extend into the pharynx. Artificial airways, that are placed through the mouth and or the nose into the trachea are usually called endotracheal tubes. So there's two different ways that we can intubate it. The process is called intubation. There's two different ways we typically intubate, and that's either oral tracheal, which is most common, where we're inserting it into the mouth and then into the trachea, or nasal tracheal intubation, where we're passing it through the nose first, which is less common. So, like I said, oral tracheal intubation, nasal tracheal intubation, and then finally we have tracheotomies, which is that surgical intervention where we're not going through the upper airway at all. We're just surgically making an incision directly into the trachea. Okay, so the indications for any of these tracheal airways is to relieve any upper airway obstruction that may result in like laryngospasms or epiglottitis or glottic edema in the upper airway. We'll put in endotracheal tubes to protect the airway. So if a patient's like having a seizure and we need to protect their airway during the seizures, we would place an endotracheal tube. If patients can't manage their own secretions, we would use endotracheal tubes to help facilitate tracheal suctioning or a tracheostomy if it got to that point, and then to assist with manual or mechanical ventilation. So if we feel like the patient needs to be mechanically ventilated because their work of breathing is too excessive or they're not, don't have adequate respirations, then we would place an endotracheal tube in and hook them up to the mechanical ventilator. So there's several hazards for intubating a patient and putting them on a ventilator. Contamination is probably going to be the first one. Anytime we're introducing something into the body, performing an invasive procedure, you risk introducing microorganisms down into the lower airways, and that can increase risk of infection. So you're going to learn in mechanical ventilation next semester all about ventilator-associated pneumonias. This is a quality tracking endeavor that all hospitals follow up with because ventilator-associated pneumonia is considered a preventable hospital-acquired disease or disorder, and we, as respiratory therapists, work really closely with the ICU nursing staff to ensure that we're following certain hospital established bundles of care to try to prevent these. We talked about them a little bit when we talked about infection control in the survey. We talked about this. When I'm intubated, I'm usually going to need to be on a lot of sedation. That's going to reduce my coughing mechanisms. This tube goes through the vocal cord, so long-term intubation could cause damage to the vocal cords, or the process of during the procedure of intubation, damage could be caused to the vocal cords. Swelling, edema in the laryngeal tracheal area can occur from intubation, mucosal damage. These tubes are going to be smaller than your actual airway, so are more likely to become occluded, and that occlusion will cause the patient not to be able to breathe. You can have something called tracheal malaise occurring, where you have the rigid cartilage in the trachea can kind of start breaking down and become floppy, which causes long-term complications with respirations, and typically those patients, if they've developed tracheal malaise, require long-term tracheostomy tubes in place. And again, because our endotracheal tube is narrower than our actual airway, that's going to increase our airway resistance. Okay, so I think, and again, we had some issues in lab last week because I was sick, but we talked about, with some of you, the Mallampati classifications. So your Mallampati score is I think this is something that you should probably remember, because I feel like this is a common board exam question, something to do with Mallampati scores. This is just something you can perform on yourself. Go in the bathroom, open your mouth wide, say ah, stick your tongue out, and see how much of your soft palate and uvula you can visualize. So if you're like class 1, which is the first picture, when you open up wide, you're going to see your uvula hanging in the back, and you're going to be able to visualize your soft palate. If you're class 2, you should be able to still visualize your uvula, maybe not be able to see your soft palate as well. So classifications of 1 and 2, typically these patients are fairly easy to intubate. Okay. When you get to class 3 or class 4, this is where you're considered, if this patient's most likely going to be a very difficult intubation, because class 3 and 4, how their tongue is kind of situated in and attached in their airway is going to be kind of make a more obstructed view. So the higher the class of Mallampati score, the more difficult the intubation will be. And this also typically will put the patient at a greater risk for disorders like obstructive sleep apnea as well. So that's your homework. Go in the bathroom, go take a look at your back of your throat, and come to class knowing your Mallampati score for a lab this week. Okay. So complications with intubations can be, if the patient's not fully unconscious, it can be very difficult to do this. Imagine me trying to stick something in the back of your throat and open up your airway and shove a tube down your throat. You wouldn't like it very much. So you really want to make sure that the patient's adequately sedated before attempting this procedure. Sometimes endotracheal tubes can be difficult to stabilize. Once they're in, we want to keep them in, so we want to make sure we can secure them, and occasionally they can be a little bit challenging to stabilize depending on what the patient's situation is. You'll notice this with your patients when you get into the ICUs, is that a lot of times if you're intubated, especially orally intubated, that usually causes a patient to produce a lot of excessive amounts of oral secretions. So you're going to be suctioning the oral airway a lot. It's going in the back of the throat, so the patient can have some gagging if they're not properly sedated. They might become agitated and bite on the tube and occlude the airflow. Patients aren't going to be able to communicate if they're intubated because it's going through their vocal cords. And then with securing these, a lot of times you can end up having some skin breakdown as a complication as well. That's something also that we really need to be aware of and be on top of to try to prevent that from happening. Okay, so kind of the difference between oral and nasal, just knowing that nasal tracheal tubes, they're typically a little bit longer, and they have a longer length than oral tubes. So if you are going to be nasally intubating a patient, you could use an oral tube, but just know that it might be a little too short. So they do make specialized nasal ones that are a little bit longer. Nasal tracheal intubations is not usually the preferred method, but we do it for blind intubations. So if I know that a patient needs to be intubated, it's not like emergent, the patient's still conscious and alert, but I believe that they're going to be a really difficult intubation, I might attempt to do a blind nasal intubation first, which is essentially what you're trying to do is just trying to nasal tracheally sectioning somebody. It's the insertion's kind of the same way, but it's with a really big tube. So the benefit of that is the patient can be alert and breathing. You advance that tube as that patient takes those deep breaths or coughs, and you don't have to sedate the patient, so you don't risk having difficult time ventilating the patient while you're trying to put these devices in. So some other advantages of nasal tracheal tubes is that they're easier to stabilize. It's not in the patient's mouth, so it's going to be, they're not going to be maybe biting on it, they can't bite on it and won't produce as much oral secretions. You still have some complications of skin breakdown, and because you're going through those nasal passages and your nasal passages are attached to your sinuses, your patients that have nasally intubated may be at more risk for like the ear infections as a complication. Okay, so now some other additional information about endotracheal tubes that are out there. We have these high-low evac tubes that have a special port along the side that we use for suctioning subglottic secretions. So some places use these as standard practice to help prevent ventilator-associated pneumonia. I actually, interestingly enough, did a really huge, big research project for grad school. Can't remember which class it was for now, but one of my classes I had to write a big paper about this, about the different types of what pieces of these vent bundles actually made a big difference. And this was one of those things that had come out, and it seems like a really great idea, because what this little extra section does is it allows you to suction whatever secretions are sitting right here at the top of this cuff. I have never really liked these tubes. I feel like they get plugged up and occluded really easily, and they don't ever work the way they're meant to or intended to, or or as easily as they're intended to. They make it sound like these are so easy, but in my experience, that you can run into problems with them getting occluded, and then trying to get them to actually suction out the secretion sometimes is harder than what they try to promote it being. But yeah, when you do lit reviews on this, it's not like this is the end all be all cure of everything like they try to say it is. And not to say that people shouldn't use them, but I think with everything, as you guys get further into your respiratory careers after you leave me behind, you might want to just pay attention to these types of things. And when you get these new products into your hospitals, do some digging and research on your own, looking at literature and seeing how beneficial these really are, because these are quite a bit more expensive than regular endotracheal tubes, and I'm not entirely sold on whether or not they're worth the extra cost. We also have something called tube exchangers. So these help facilitate intubation or tube replacement. So this blue, I think we should call that blue guy here, this is called a bougie. We have these in the lab. I'll show you them. What you can do with this is you can insert it down the endotracheal tube. So if I needed to exchange a tube, the patient was intubated, or I needed and the pilot balloon blew, or I needed to put a bigger size endotracheal tube in after we intubated, I could insert this down the existing airway, pull the old tube out, leaving this in place, and then slide a new tube over it. So you have an RCC on tube exchangers, and we'll be playing with that in lab in week 3 of this module. So that's a bougie, but they also have Cook tube exchangers where you can actually ventilate through this as well. I mean, the airway resistance is really high, but if you needed to be able to ventilate while you were trying to do this procedure of exchanging the tube, you could use a Cook tube exchanger instead of a bougie. All right, so these are kind of your parts and pieces of an endotracheal tube. So typically you have this standardized 15 millimeter connector on the top. And this means that it's going to be compatible with any manual ventilation device and that mechanical ventilation circuitry. So typically they use, there's like a radiopaque line on the side of these tubes so that it'll show up on x-ray easily, be very visible on x-ray. The inner diameter of this tube is what's marked on the side of the endotracheal tube. So this is a size 8. Okay. The outer diameter is, measured in millimeters. The tube number on these sides is what indicates the depth. We use this for knowing the position of our endotracheal tube. So typically whenever you're doing your documentation, you're going to document the size, so size 8, and then the marking at the teeth or the lip of the patient. So if the patient's teeth are about here, I would say it's a size 8 at, if it was right here, it would be 23 at the lip. This solid black line here is what you should be looking for if you're the intubator, to see that pass through the vocal cords. Once that's passed through the vocal cords, you're at probably the proper depth of where you need to be. There's a pilot balloon on the end that's attached to this pilot line, and that is what we use to inflate this cuff down here. Okay, so we typically like to keep anywhere from about, around 25 millimeters of mercury of pressure in this cuff. If you use too much pressure in this cuff, we're going to talk about it later with managing artificial airways. You could put yourself at risk of occluding some of those pulmonary those capillary beds in the trachea and causing some tissue necrosis. So you don't want to use too much air in this cuff, but you want to have enough in it that it seals off the airway. This hole on the bottom of the tube is called a Murphy eye. It's to prevent any obstruction of that endotracheal tube. So if something occludes the endotracheal tube down here, you still have that Murphy eye that can allow for ventilation. And then your beveled tip kind of just increases the view of the vocal cords, less likely to become occluded against the trachea or with secretions because it has that beveled tip. So that's just kind of the parts listed out for you. This just is a chart that talks about the different sizes for females and males. So typically adult females is somewhere from 7, usually 8 is the biggest I've ever seen in an adult female. And you're usually looking for securing around that 20 to 23 centimeter mark at the teeth. For adult males, you're using larger size tube. Men are usually bigger than women, so you're looking at more 8.5 sized endotracheal tubes for adult males. You can go all the way up to 9.5 depending on the size of the person. And you're looking at more of like 23 or 22 to 25 centimeters at the teeth. Okay. So for your procedure, you need a couple pieces of equipment. You need a laryngoscope handle. So they make disposable ones that have fiber optic lights, or you have like non-disposable ones that have replaceable batteries. There's a hinge on the top that the blade attaches to. And there's this electrical contact so that when the blade's attached properly, that's what's going to turn on the light. There are 2 types of handles that we use for intubation. There's one that's called a Miller or a straight blade, and there's one that's called a McIntosh or a curved blade. Okay, and depending on which type of blade you decide to use, you're looking for different landmarks in the airway. So with the McIntosh blade, you're looking to insert the tip of the blade between the vallecula into that vallecula, that space or crevice at the base of the tongue, between the base of the tongue and the epiglottis. With a straight blade, you're supposed to look for the when you see the epiglottis, you're supposed to insert this over the top of it and lift the entire epiglottis out of the way for your view. So depending on the type of blade you're using, you're going to insert it into a different area into the airway to open up the airway. Most everybody I know that intubates usually prefers a McIntosh for an adult, for adults, and we usually use Miller's for babies. That's not to say that, some doctor, wants to be different and wants the Miller blade for the adult patient. That's something that you just ask if you're assisting in the intubation and you're not sure, you can just always ask that question. It's like, do you want to, or have the other blade out just in case they want to do something different. Okay. So when you're setting up for intubation, good practice is just have the ventilator that you're going to want to put the patient on set up and ready, and on standby behind you. That just helps you out so that you're not spending hours bagging or minutes bagging the patient after the procedure. You can just hook them up to the ventilator. You want to make sure you have suction set up, and you want to have that Yankauer or that oral wand to clear the upper airway during the procedure. You want to make sure that you have a resuscitation bag with mask and a PEEP valve, if applicable, in place, and make sure that it's hooked up to oxygen and the oxygen's on, the flow meter's open all the way and you're giving 100% oxygen. So depending on the patient's size, you want to select the appropriate size and type of blade. You want to connect the scope and the blade together and make sure that the light's working. You want to select the appropriate size endotracheal tube for the patient. And make sure that it is working properly. Whenever you're going to be manually ventilating, like I said last week, you want to use oral airways. Just why work harder? So you want to make sure you have the proper size OPA available as well. So when you're making sure that your endotracheal tube not only is appropriate size, but you want to make sure that the cuff is working, because the last thing you want to do is get the patient intubated and then realize that you can't inflate your cuff because your pilot balloon's blown or something malfunctioned with the endotracheal tube. So you're going to inflate the cuff, make sure there's no leaks. I usually lubricate the cuff just to help ease it through the vocal cords. Insert a stylet. Make sure that you have it shaped properly for the patient, and then you would want to have that 10 cc syringe handy to inflate the cuff afterwards. Then you also want to make sure that you have devices to check for placement available, so like a end-tidal CO2 adapter or a colorimeter. And if you're the one that's assisting in the intubation, you're going to just want to make sure that I typically recommend standing on the right side of the person intubating, or the patient's right side, because you're going to be handing the endotracheal tube into their right hand. So once the patient gets their view, or the doctor or whoever's intubating gets their view, they don't want to take their eyes off the cord. So you want to, be able to put the device in their hands so they can quickly insert it. So after the patient gets intubated, then you're going to inflate the cuff and confirm placement. So you're doing that by listening for bilateral breath sounds, looking for that exhaled CO2, analyzing that either with a colorimeter, having it turn yellow to show you that you got into the right place, or by using capnography, waveform capnography, to confirm placement. Humidification in the tube also can be an indicator, but it's not usually the best indicator. So really it's bilateral breath sounds, capnography, and then it's usually followed up by a chest x-ray. So you're going to get a chest x-ray and see that the tube should rest about 3 to 5 centimeters above the carina. Okay, so this is that radiopaque line, and you kind of see the tip of the tube there. So here, this is where the carina is, and we're about at T3 or T4 vertebrae. which is a good placement. Sees. Okay. So again, if you're assisting with intubation, you're standing at the right side of the intubator. You're going to be, doing all the things like you said, like you would do with intubation, ensuring that the patient's adequately oxygenated, ventilating the patient, monitoring the patients during the procedure. And then your job really is to kind of just have that equipment set up and hand the endotracheal tube to the intubator when they request it. You may also be asked to perform something called cricoid pressure, which is applying pressure to the cricoid cartilage on the patient, which can help drop those cords into a more posterior view, to make them a little bit easier for the doctor to visualize. I will say that bad cricoid pressure is worse than no cricoid pressure at all. So I always get very frustrated when I was an intubator and somebody would be trying to help me and they would do cricoid pressure and they would just kind of push on the neck randomly. And it's just like, well, if you're not going to do it right, don't do it, because then that actually makes your view worse. So you want to actually make sure that you're finding the cricoid cartilage before you push down, so that you can drop those cords back into view. Okay, after they insert the endotracheal tube, you will remove the stylet for the person that's intubating, fill that cuff with air, and help verify the placement. Once placement is verified, then you can secure the endotracheal tube and apply the ventilator. Okay. So we've talked about inflating the cuff a couple times. We're going to talk about this a little bit more when we talk about maintenance of the airway, which is the next module. But we want to make sure that we aren't using too much pressure to inflate the cuff or too little pressure. So you want just the right amount of air in that cuff to ensure that if you have not enough air in the cuff, there's secretions will leak down around the endotracheal tube and get into the lower airways and cause pneumonia. If you have too much pressure in the cuff, you will occlude those tracheal capillary beds and cause tissue necrosis there, which can lead to long-term complications. So you usually want to keep the cuff pressure somewhere between 20 and 25 millimeters of mercury or 25 and 35 centimeters of water pressure. And that video did not work. Let's make sure that works on the published PowerPoint. Okay, there's several securement techniques that we have for devices. So we sometimes will use tape. Tape has fallen out of favor, many, many years ago because we have all these fancy commercial devices that we use. Typically, most places I see use this one. It's called the Hollister or Anchorfast. I'll show you how to put these on in lab. And we also have the Comfit, which we'll also use in lab, and show you how to secure this airway with both of those. The problem with these commercial devices is they are a little prone to skin breakdown, especially now that COVID has been such a big thing and we've started proning our patients again, where we're flipping them over on their stomachs to help with ventilation and perfusion. And so they spend like 16 hours a day lying face down in bed while on the mechanical ventilator. And they end up with really, really, really bad skin breakdown potentially. So we've gone back to taping tubes on those types of patients specifically. And I'll show you a couple of different taping techniques as well. Okay, so just a little practice question here, just to get you kind of thinking about stuff. So after you intubate the patient, you inflate the cuff to about 35 centimeters of water, and a leak is heard. Okay, so we've inflated it to 35 centimeters of water, which is the high end of the range. So if we still have a leak, do we want to use a minimal occlusion technique to determine volume needed to seal the airway? Should we allow for that site leak so you don't use excessive pressure? Or should you re-intubate the patient using a larger endotracheal tube? Okay, so this is the type of question that they might ask you on the MBRC exam about your knowledge of cuffs and managing airways. So the thing that I need you to remember is your range, your safe range for cuff inflation is 25 to 35 centimeters of water pressure. So you are not going to exceed that pressure, okay? The answer is never go up to 40 to get rid of the leak. So A really isn't a good option because minimal occlusion technique says that you're going to keep inflating that cuff until you hear no leak around the airway. Okay, so you're not going to want to do that because that in this scenario, that would be over 35 centimeters of water pressure, which is never okay. If we allow a slight leak, what that's going to do is, again, put my patient at risk for their secretions traveling down into their lower airways and causing pneumonia, or it could also mean that I will have trouble maintaining my tidal volumes, and might not be able to adequately ventilate my patient. Okay, so if those things are present, that's not usually an ideal answer. So your best answer actually is C here, where you're going to reintubate the patient with a larger endotracheal tube. And that is because what happens when you put in a small tube, you're going to need a lot of pressure to fill up that airway. So if I intubate, Shaquille O'Neal with a 6'5" endotracheal tube, that tube is going to be like a little coffee stirrer that he's going to be breathing through. So I'm going to need a lot of pressure in that cuff in order to seal off that airway. So by just simply removing the smaller tube and putting a larger tube in, I would need less pressures to seal that airway, and that would be the correct answer of C. Oops, I got it. Okay, oops. Oh, I got duplicate sides here. Sorry. There we go. Okay, so tracheotomies. This is a procedure, like I said, that establishes access to the trachea via like a neck incision. So it's either traditional surgery tracheotomy, or sometimes they'll do like a percutaneous dilated tracheotomy can be performed. I've seen these performed at bedside using bronchoscopes to help facilitate putting in the airway, surgical airway. So that opening in the neck is called that tracheostomy. The procedure is usually performed by a physician or surgery in that surgical setting after you've kind of established an airway. And you're going to select different trach tubes depending on the patient's age, height, weight, and their kind of airway anatomy. So we'll talk more in lab about the different types of trachs and what the differences are, because I feel like sometimes just holding them and using them makes it a little bit more understandable. So we do tracheostomies to bypass upper airway obstructions. So if I cannot get somebody intubated, they might have to go to surgery and get a trach placed, that surgical airway placed, because we can't get through the upper airway. We also do tracheostomy tubes to prevent problems posed by like the oral or nasal endotracheal tubes. It allows the patient to swallow and receive nourishment while they're on the mechanical ventilator. And really, they're what we need for that long-term airway protection, or to facilitate long-term mechanical ventilation. So after the patient's been intubated for about 21 days or 3 weeks, we typically are looking to get a tracheostomy placed. So this is just kind of an example of a basic tracheostomy tube. This is a Shiley brand trach. So you have this outer cannula, that has a flange on the top to help with placement, and then this is that universal 15mm adapter. There is a cuff that's attached to the pilot line and pilot balloon, so that will inflate this cuff here. And then an inner cannula goes down the inside of this tracheostomy. We have an inner and an outer cannula, so the outer cannula always stays in the track to keep things open, but the inner cannula can be removed if there's an occlusion. All I have to do is pull out the inner cannula. That should clear the occlusion. And then that also is part of trach care. Cleaning is just cleaning that inner cannula or replacing it daily. Finally, this device down at the bottom called an obturator. This is what we need to place inside the outer cannula during insertion. So you see here how there's this rounded tip on the end that just helps facilitate insertion of the tracheostomy tube. So we're not going to be the ones that are putting in the initial tracheostomies, but we are definitely going to be exchanging trach tubes. I've exchanged 1 million trach tubes, and you guys probably will do your fair share of trach tubes too by the time you get to where I am in my career. So you always want to make sure that you keep that obturator somewhere handy at the bedside. So typically a safe practice with anybody that has a tracheostomy in place is to have a spare trach at the bedside just in case they pull it out or it gets dislodged. And then the obturator also at the bedside for the trach that's currently in place just in case, again, the tube gets dislodged for any reason and you need to be able to put it back quickly. So this video is going to work.
Now Mr. Lover, she call me Mr. Boom.
Tracheostomy is a procedure in which an artificial opening is created in the throat to assist with patient's breathing or to create an alternate airway. It is a fairly common procedure in patients with prolonged ICU stay or ventilator support. Indications for tracheostomy. Tracheostomy may be needed when there is 1. Some sort of upper airway obstruction, e.g. cancer of the larynx, laryngeal edema, etc. 2. If patient is unable to remove respiratory secretions, e.g. coma, respiratory muscles paralysis. In such cases, tracheostomy allows suctioning of the secretions and the cuff of the tracheostomy reduces further aspiration of secretions. 3. If the patient has respiratory insufficiency, e.g. chronic lung diseases, then tracheostomy might help oxygen ventilation by reducing respiratory dead space. 4. Prophylactic measures. In a patient on prolonged mechanical ventilation via endotracheal tube, there is a risk for tracheal stenosis. So in such patients, tracheostomy is done. 5. As part of another procedure. Sometimes tracheostomy is done to gain access to airway for general anesthesia, or as a precautionary measure in some patients who undergo an extensive neck surgery. Type of tracheostomy. There are various types of tracheostomy procedures, depending on the circumstances of the patient and the treatment intent. Similarly, there are various types of tracheostomy tubes, each with specific functions. The common types of tracheostomy procedures are 1. Emergency tracheostomy, 2. Elective tracheostomy, 3. Permanent tracheostomy, 4. Percutaneous tracheostomy, 5. Mini tracheostomy, also known as cricothyroidotomy. Tracheostomy can also be classified as high, mid, or low, depending on the level at which it is inserted into the trachea. Different varieties of tracheostomy tubes include cuffed, non-cuffed, double lumen tubes, tubes with speaking valves, metallic tubes, and so on. Procedure. The procedure is preferably done under general anesthesia, but emergency cases may necessitate local anesthesia only. There are variations on the technique of the procedure, but generally, these are the steps. The patient is put in a supine position, with neck extended. Skin incision, which may be transverse or longitudinal, is given on the neck. Subcutaneous fat and platysma are cut. Strap muscles of the neck are retracted or dissected away. If thyroid gland is encountered, then it is displaced upwards, or may be cut. Any blood vessels encountered along the way are ligated. Incision is given on the trachea. A hole is made and the tracheostomy tube is inserted, preferably through the second or third tracheal ring. The skin incision is closed and the tracheostomy tube is secured to the skin via stitches or simply tied around the neck. Care. After tracheostomy is done, certain precautions and care is required to ensure proper functioning of the tracheostomy tube and to prevent complications. The tracheostomy forces the air to bypass the nasal and oral passages. Hence, the air entering the tracheostomy is not adequately humidified. This dry air leads to increased tracheal irritation and secretion production. Because these secretions may lead to crusting and blockage of the tracheostomy tube, the first point regarding care is adequate suctioning of the secretions through the tracheostomy tube. Secondly, humidification of air. This can be done with humidified air attached to the tube, placing a humidifier or steam near the patient's bed, or applying a wet porous gauze onto the tracheostomy tube, although the latter is considered a crude measure. Thirdly, keep the patient under regular supervision and ensure that the tube is functioning and not dislodged. Since the tracheostomy forces the air to bypass the vocal cords, patients would not be able to speak effectively. In such cases, a notepad and bell should be provided to the patient to allow them to communicate effectively with their healthcare providers. Fourthly, if the patient has a cuffed tracheostomy in place, then the cuff should be deflated periodically to relieve pressure on the trachea. However, this may not be feasible in patients with increased risk of aspiration. In case the tracheostomy tube is damaged, infected, occluded, or non-functioning in any way, then a new tube should be inserted in place of the old one under expert supervision. Complications. Just like any invasive procedure, tracheostomy also has some potential complications. Surrounding structures may be damaged while performing the procedure. Therefore, there could be bleeding around the tracheostomy site. Tracheostomy tube may get blocked by secretions or clots, or it may get dislodged. The dry air directly entering the trachea might cause tracheitis or crusting. The patient may have initial difficulty getting used to breathing via tracheostomy, along with apnea. There may be infections of the surgical wound, trachea, or lungs. Decannulation. If the patient improves and the healthcare team determines that tracheostomy is no longer necessary, then a trial of decannulation should be attempted. Decannulation is basically the removal of the tracheostomy tube and shifting the patient back to normal breathing. The tube is occluded for 24 hours, and if the patient is able to tolerate it and breathe normally, then the tube is removed and the wound closed. If patient is unable to tolerate the tube occlusion, then progressively smaller tracheostomy tube are inserted and occluded until patient is able to resume normal breathing.
Okay, so that gave you kind of a big overview of trachs and just kind of trach care. A lot of that we're going to go a little bit more in depth in managing the airways a little bit later on. But I felt like that video had some good visuals with everything, so wanted to include it here. Finally, the last kind of surgical procedure that I wanted to talk about with airways is laryngectomies. So laryngectomies are different than tracheostomies. So in a laryngectomy, the patient is going to have their entire voice box removed. Okay, so this is typically done to treat laryngeal cancer. It's also done in patients with trauma, or if they've had any type of radiation necrosis. A lot of times patients that have lung cancer are going to have radiation therapy to their lungs that can also affect their throat. And that might necessitate a laryngectomy as well. So what happens is the surgeon is going to create a stoma and attach a trachea to the stoma. These laryngectomy tubes may be inserted into that stoma to keep it open while it heals. And then the patient, after the stoma heals, they're going to breathe through that permanent stoma. So if you look here, at this, So let's keep going. This picture here, this is kind of where the site of what gets removed. So they're kind of removing these whole vocal cords and everything. And you don't kind of have, and then the trachea just goes to that stoma in this picture. So you no longer have an upper airway access at all when you have a laryngectomy. Okay, so once the patient has a laryngectomy, they don't access their airway through their nose or their mouth ever again. They also have their voice box removed, so these patients aren't able to, talk normally anymore. Okay, so that kind of concludes the second part of your lecture for artificial airways. There was only 2 parts to this module's lectures. We are going to be in week 2. We are going to be going of this module. We're going to be going through the process of endotracheal intubation. We'll be looking at some of the artificial airways I discussed in this lecture. And then week 3, we'll talk more about week 3 of this module, we'll talk more about tracheostomy tubes.